Welcome. In this session, we'll be discussing about normal tension glaucoma. We have discussed about IOP measurement techniques, gonioscopy techniques and findings, optic nerve weight changes, visual field changes and OCT changes characteristic of glaucoma in their respective sessions previously. In this session, we'll be discussing about the profile of normal tension glaucoma patients, differential diagnosis of normal tension glaucoma, and treatment of normal tension glaucoma. Normal tension glaucoma is an open-angle glaucoma in which IOP is consistently less than 22 millimeters of mercury, and this is an important figure to remember. Normal tension glaucoma has been found to constitute 30 to 50% of all open-angle glaucoma cases. And in Japan, more than 90% of all open-angle glaucoma patients have been found to have intraocular pressure less than 22 millimeters of mercury. Like primary open-angle glaucoma, normal tension glaucoma is usually bilateral but asymmetric, often with more severe disease in the eye with higher intraocular pressure. And normal tension glaucoma is prone to be missed if glaucoma diagnosis is based only on intraocular pressure measurement, and this is very important to understand and remember. In normal tension glaucoma, intraocular pressure is usually found to be in the high teens, that is more than 15 millimeters of mercury, rather than in the low teens, that is less than 15 millimeters of mercury. And pathogenetically, optic discs in normal tension glaucoma are considered to be susceptible to glaucomatous damage at a lower intraocular pressure, and this susceptibility can be due to various reasons such as connective tissue weaknesses, vasculopathy, inflammation and autoimmunity. Like primary open-angle glaucoma, in normal tension glaucoma, diurnal variation of intraocular pressure is larger than in normal individuals. And even though IOP is in the so-called normal range in normal tension glaucoma, IOP is still the only treatable risk factor in normal tension glaucoma. Risk factors which are more commonly found in normal tension glaucoma as compared to primary open-angle glaucoma are chiefly vasculopathic, potentially impairing optic nerve weight blood flow, and they include migraine, Raynaud's phenomena, nocturnal hypotension, coagulopathies, autoimmune diseases, and sleep apnea. And these are important to remember. Clinical features found more commonly in normal tension glaucoma as compared to primary open-angle glaucoma include optic disc hemorrhage and visual field defects which are focal, deeper, and nearer to fixation. However, these clinical features do not differentiate between normal tension glaucoma and primary open-angle glaucoma by themselves. Some studies have found that optic disc changes in normal tension glaucoma is more likely to be focal in nature, but this association is not universally accepted. Differential diagnosis of normal tension glaucoma is important. First among them are primary open-angle glaucoma cases in which intraocular pressure recordings are normal during clinic hours when intraocular pressures are recorded, but intraocular pressures are higher late at night or early in the morning and thus escape detection. And to differentiate between these two entities, monitoring diurnal variation of IOP can be helpful. The other differential diagnosis includes entities in which there is a previous episode of raised intraocular pressure which has now normalized either spontaneously or following treatment. Systemic or topical steroids, uveitis, and pigment dispersion syndrome can lead to such an episodic rise of raised intraocular pressure, and IOP lowering treatment and systemic beta blocker therapy can normalize a previously raised intraocular pressure. Optic nerve anomalies and disorders also come in the differential diagnosis of normal tension glaucoma, and the most common among them are normal individuals with a physiologically large cup. Optic neuropathies such as compressive, ischemic, congenital, toxic, and nutritional optic neuropathies can resemble glaucomatous optic neuropathy, and specifically arteritic acute ischemic optic neuropathy and compressive optic neuropathy are known to produce significant cupping. Chorioretinal lesions causing visual field defects mimicking glaucomatous visual field defect also come in the differential diagnosis of normal tension glaucoma, and among them myopic eyes are the most important and the most difficult to differentiate. Myopic eyes without glaucoma can have chorioretinal degeneration with visual field defects mimicking glaucoma, but the visual field defects in this situation are non-progressive or very slowly progressive. On the other hand, myopic eyes are prone to develop glaucoma, often with IOP less than 22 mm of mercury. And in addition, myopic optic nerve changes such as tilt, torsion, pedipapillary atrophy can make it difficult to detect glaucomatous changes. As we have discussed in an earlier session, osity of optic nerve head, retinal nerve fiber layer as well as macula may be misleading in myopia, because in myopia, particularly in high myopia, there is temporal displacement of both the superotemporal and the inferotemporal arcuate bundles, resulting in sectoral changes in both the thickness of the pedipapillary retinal nerve fiber layer and the width of the neuroretinal rim as compared to the sectorial parameters in normal individuals. So, detection of progression of visual field defects and OCT features in myopia is key to detecting glaucoma in these patients, and this is very important to remember. Since the branches of the central retinal artery supply the superficial retina, branch retinal arterial occlusion affects the superficial retina, including the retinal nerve fiber layer, and produce visual field defects mimicking glaucoma. Management of normal tension glaucoma is primarily reduction of intraocular pressure. The collaborative normal tension glaucoma study, or the CNTGS, found that 30% reduction of IOP from baseline reduces the risk of visual field progression threefold, from 35% in untreated eyes to 12% in treated eyes within 5 years. And it has been also seen that treatment is less effective in patients with optic disc hemorrhage at baseline. So 30% reduction in IOP from baseline is recommended in normal tension glaucoma. And we have discussed the concept of target pressure in the previous session on primary open-angle glaucoma. Treatment initiation may be delayed in an elderly patient with IOP in the low teens and with early visual field defects, but treatment is indicated in younger patients with intraocular pressure in high teens, significant visual field defects, and or migraine. Beta blockers should be avoided in treatment of normal tension glaucoma because the early manifest glaucoma trial showed little IOP lowering effect of betaxolol combined with argon laser trabeculoplasty in normal tension glaucoma, and low pressure glaucoma treatment study showed high rate of glaucoma progression in NTG patients who have been treated with timolol, and this has been said to be due to reduced ocular perfusion pressure with beta blocker therapy. Surgical reduction of intraocular pressure is often required to arrest visual field progression in normal tension glaucoma, and significant proportion of normal tension glaucoma patients with intraocular pressure in the low teens have been found not to respond adequately to medical therapy and progress. In CNTGS, 43% of patients required surgery. Trabeculectomy with mitomycin is the recommended procedure to achieve single-digit IOP levels in patients having IOP in mid to low teens. But there is no role of minimally invasive glaucoma surgery or glaucoma valves to achieve these IOP levels. Other than reduction of intraocular pressure, correction of cardiovascular comorbidities, if any, is recommended in normal tension glaucoma, which may include avoiding nocturnal dips in blood pressure and treatment of associated anemia, congestive heart failure, transient ischemic attacks, and arrhythmia. Concomitant use of systemic calcium channel blockers have been shown to reduce progression of normal tension glaucoma. And just like any other glaucoma entity, long-term monitoring with ONH photography, visual field testing, and OCT analysis is recommended in normal tension glaucoma. In appropriately treated normal tension glaucoma patients, 20-year rate of unilateral and bilateral blindness has been found to be 10% and 1.4% respectively, and predictors of progression in normal tension glaucoma include female sex, migraine, and occurrence of disc hemorrhage. To recap the salient points, normal tension glaucoma is an open-angle glaucoma occurring with IOP consistently below 22 millimeters of mercury. Normal tension glaucoma is prone to be missed if glaucoma diagnosis is based solely on raised intraocular pressure. Certain risk factors are more commonly found in normal tension glaucoma as compared to primary open-angle glaucoma, and they include migraine, Raynaud phenomena, nocturnal hypotension, and sleep apnea. Certain clinical features which are more commonly found in normal tension glaucoma as compared to primary open-angle glaucoma include optic disc hemorrhages and visual field defects which are focal, deeper, and nearer to fixation. However, these clinical features by themselves do not differentiate between normal tension glaucoma and primary open-angle glaucoma. Differential diagnosis of normal tension glaucoma include primary open-angle glaucoma with diurnal variation, normalization of previous episodes of raised intraocular pressure, non-glaucomatous optic neuropathies, and chorioretinopathies causing visual field defects resembling visual field defects of glaucoma. Treatment of normal tension glaucoma is lowering of intraocular pressure, and a 30% reduction of intraocular pressure from baseline is recommended. Beta blockers should be avoided in the treatment of normal tension glaucoma, and in normal tension glaucoma, incisional surgery to reduce intraocular pressure is often required. Thank you for listening.